A very good afternoon. Today we'll be discussing some of the aspects of genetic testing in pediatric ophthalmology. Basically, the phenotype-genotype correlations, when we would order a genetic testing, why we need to do it, and what type of a genetic testing would we need to have in order to know actually what we're dealing with. So it will be a case-based approach. We have different cases ranging from cornea, strabismus, cataract, and retina as well, neuro-ophthalmology, of course. So the course outline would be something like that. So we have one case in pediatric cataract, the other in strabismus, third in retinal abnormality, childhood glaucoma, optic dysphalia, and corneal disorder. So we'll be covering these 6 cases. So starting with the first case, I'd like to, there's a little change in order. Like Dr. Shweta Chaurasia will be presenting first because she has to go for a Rangachari session. So just a brief introduction. She's an additional professor at the Advanced Eye Center, PGI Chandigarh. Of course, she's done a lot of work in CVI as well now recently. And she's got numerous publications. She's also the reviewer for various committees. She's won the best poster for strabismus and various named awards. And without wasting much time, I'll request her to please start her presentation.
Thank you, sir, for the opportunity and the kind introduction. So my topic is genetic testing in a case of strabismus. So what are the questions which come to the mind while we think about the genetics in strabismus? So is there any role of genetics in strabismus? And when to do, if there is a role, when to do genetics in strabismus and why to do? Will it help in managing the case better? So I will be focusing on these points. So what does the literature say? About the twin and family studies, Hippocrates first noted that strabismus run in families. And twin studies have supported a strong genetic contribution, particularly for ESO deviations. Monozygotic twins have concordant rates of strabismus around 50 to 82%, and in our clinic also we have found 2 monozygotic twins having ESO deviation at the same time. So is there any, is strabismus a Mendelian disorder? In large strabismus pedigrees in which strabismus is inherited is in apparently Mendelian pattern, several studies have used linkage analysis to identify the potential loci. And one of the loci is 7p22.1 STBM1, which was mapped in one large family. So what does the genome-wide association studies tell? The diseases that are common in the population often have multiple genes that contribute, with each individual variant having a small effect size. And one of the studies on non-accommodative esotropia, 826 patients of European ancestry from the USA in discovery cohort and 689 patients from Australia and United Kingdom in the replication cohort have found functional single nucleotide polymorphism in the intron region of the WRB gene on chromosome 21. So coming to the copy number variants and single nucleotide variants and genetic syndromes, I will be showing with the help of cases. So coming to the case 1, an 8-year-old male presented to the eye clinic with congenital severe ptosis with poor LPS, infrareducted eye position and chin-up head posture. His birth and development history were normal. The best correctal visual acuity was 624 and he had compound hyperopic astigmatism. Anterior segment was within normal limit. Posterior segment had subtle disc pallor. So he had positive family history. When we charted his family history, it dates to around 4 generations. And you could see his father also having the same problem. So when we assessed him in a detailed manner, we found that you can see that both the eyes are infraducted. The eye is not able to come in the primary position. And you could see there is a perverted convergence in up gaze. And there was a divergence in down gaze. And also there was an adduction deficit in the left eye along with some down shoot. So when we did an MRI, we found that the 3rd nerves were attenuated and even the 6 nerves were attenuated. On the quasicoronal MRI orbit images, we could find that the superior rectus were very, very thin and even the medial rectus were very thin and even the inferior oblique. And there was a Y-shaped accessory muscle at the back of the orbit. When we saw the MRI brain images, we saw that there was an area of parenchymal atrophy with marked thinning of adjacent cortical gyri and subtle adjacent intraparenchymal T2 hyperintense signal in the right paramedian and occipital region. thereby implying that there was some CNS abnormality. Also, there was subtle thinning in the splenium and posterior part of the body of corpus callosum. So, this was, since there was a CNS abnormality, so it comes under CFUM3 phenotype. But to our surprise, when we did a genetic analysis, we found that it was KIF21A. So, points to ponder is that brain malformation, which are characteristic of CFUM3 phenotype, and CFA3 generally have TUB3 mutation, but only KIF21A rarely. So, our case shows the possibility of CNS abnormality with KIF21A. So, this may be because of the phenotypic overlap between the TUB3 and KIF21A mutations, which suggest a shared disease mechanism underlying the two disorders. And just a word about the pathophysiology, this kinesin dimer basically attaches and moves along the microtubule, which is critical for the human nervous system development. So, this mutation which we found in our case were not with a novel one, because it didn't match with the literature search which we did. So, take home message is that genetic can add a pathophysiological understanding of the complex condition and can help in genetic counseling. Certain missense mutations in KIF21A can harbor CNS abnormalities. Hence, genetics can further explore about the interdependent relation of KIF21A and TUB3 gene in disease pathogenesis. Now, coming to the case 2, a 16-year-old female presented with inability to elevate the eyelids, and there was both eye were infraducted. Birth and development history was normal. The best corrected visual acuity was 6/18, and there was again compound hyperopic astigmatism. Anterior segment was large, and posterior segment there was 0.7 cupping suspicious, but though glaucoma was not there. Chin up head posture up there. This was his mother having the same presentation. So this is a short video showing the both eye ptosis. There was upgaze palsy. The globes were infraducted. The chin up head posture was there. There was a perverted convergence in attempted upgaze and divergence in upgaze. So you could see there was only horizontal movement was there, and there was no up or down movement. So this is again the CFUM1 phenotype, because both ptosis, upgaze palsy, infraducted globe position. This is the classical picture in CFUM1. So when we did an MRI, we saw that the third nerves were hypoplastic, but 6 nerves were normal. The superior rectus was quite hypoplastic, and MR was also little on a thinner side. We did a dynamic MRI orbit, and we saw that there was a perverted convergence. We could document the perverted convergence. As you can see, the thickness of the medial rectus was increasing in the up gaze, and the lateral rectus were thicker on the dime gaze. So we could prove it on the dynamic orbital imaging. So, but when we did a genetic analysis, we found that it was TUB3. So there was a deletion of 19.3 kb, which was a very large deletion. So points to ponder in this case is, our case was a CFUM1 phenotype, which is mostly related with KIF21A gene mutation. And because TUB3 mutation generally presents as a more heterogeneous phenotype with unilateral and asymmetrical involvement. So, single nucleotide variant in TUB3 mutation can present as CFUM1 phenotype, and heavy deletions can cause aberrant regeneration. So, this is the patient. We did a bilateral IR recession and along with PTSO and superior oblique suture spacer. This was the first post-operative photograph, and then we did a bilateral LR recession with upshift, and this was the final outcome. So takeaway points are: the higher the load of deletion in KIF21A gene can cause more severe aberrant regeneration, and careful stage surgery should be planned to reach the good outcome. Now the last case, a 16-year-old female presented with outward deviation since birth. Birth, development and family history were not significant. Visual acuity was 6/9, 6/24. There was an anisometropic amblyopia in the left eye. Anterior and posterior segment were within normal limit. Hirschberg showed left eye hypertropia of around 45 degrees. So you could see that there was a hypertropia in both the lateral gazes, and you could see in the down gaze there was inferior rectus underaction, and in the up gaze there was superior rectus overaction. So either we are dealing with inferior rectus palsy or inferior rectus aplasia, or we are dealing with superior rectus overaction. So we did an FDT, and we found that the superior rectus was extremely tight. We were not able to move the eye. And active fourth generation test for the inferior rectus was present. So we did an MRI, and we saw that there was a superior rectus hyperplasia in the posterior orbit. So you could see here the global fibers as well as the global fibers as well as the orbital fibers were very thick. And we did the image, the third nerves, when we imaged, the third nerve was hypoplastic on the left side. So we did a left eye SR large recession of 16 mm, but still there was a residual hypertrophy of around 15 to 20 degrees. So we again did a IR application of 7.5 mm along with the IOANT, and we got a good surgical outcome. You could compare the down gaze. The down gaze has become much better, and though there was slight underaction in the up gaze, but the patient, it didn't bother the patient much. So when we did a genetic analysis, we found a ROB gene positive. And this ROB gene is the same gene which controls the neurite outgrowth and axonal fasciculation. And the slit proteins, a family of secreted chemorepellents, are ligands for ROB proteins, which regulates myogenesis. So that's explain our case. So ROB3 is also been implicated. The loss of function has implicated in horizontal gaze palsy, along with the scoliosis, which we have published in our previous paper. And it is associated with butterfly-shaped medulla and absent facial colliculi. So to conclude, with a prevalence of 2 to 4% in the population, strabismus can lead to loss of binocularity and amblyopia if left untreated. By uncovering the genetic factors contributing to strabismus, genetics can facilitate early identification of at-risk individuals, potentially paving the way for novel preventive and therapeutic strategies to mitigate the associated visual impairments. And congenital concomitant strabismus, especially the CCDDs, do have a genetic foundation which needs to be explored further. Thank you.
Thank you for those very interesting cases and how molecular diagnosis can basically help you in further planning. Everything is not basically what you see actually. So a lot of hidden things are there which you need to identify with this molecular diagnosis. So any comments, questions? Yeah, Dr. Arif, I specially called him from downstairs. Please come to our session.
Yeah, thank you. I'm sorry I missed the very beginning of it. Very nice presentation. I just want to make one comment. I don't, you have a lot of presentations in this session. But just because that a variant is found in a gene, it doesn't mean that it's pathogenic. And I think when I came in, you were talking about a KIF21A variant and a patient with fibrosis and some brain abnormalities. I'm not aware of any KIF21A, variations associated with
yes,
with
that's
brain
what
abnormalities.
I was also surprised.
So just that calls into question whether or not it's pathogenic. And also, most of the variants in KIF21A that cause strabismus are in the same residue.
Yes, I want to like to show the.
I don't want to take too much.
Pathogenic.
Time.
It was showed pathogenic. The result came as.
Did we test the family members?
The family members were not tested, but there was a 4-generation family history.
Sometimes the predictions are not correct. That happens sometimes. So, that's why the clinician is so important. The other thing I would say is, I think you were talking about a patient with Robo3 and vertical strabismus. I've never seen that. I would question that also.
So I have like 2 patients now, the ROB gene positive, the same similar kind of congenital.
Yeah, it's very interesting. I'm not saying it's not the cause, but we always have to be skeptical because just because there's a change, even if it's predicted as pathogenic, it's not always the pathogenic. Thank you.
Thank you.
I'll just make a comment. I just want to say that traditionally we don't tend to test these patients through genetic testing, and so we're not quite aware of the kind of the wealth of phenotypes that can be associated. So I want to just labor that it's a good thing to do these genetic testing. As Dr. Khan just said, sometimes you have to interpret the results carefully, but the more you test, the more we'll understand what the basis is of this. So it's actually nice to see that you're doing that. And what kind of genetic tests were you doing?
We do a whole exome sequencing.
Just quickly add that I've also looked at the HGPPS, like Dr. Khan was there at APOS when we had the posters. So with that, if you can additionally test the parents and you can confirm that the biparental segregation, then you know for sure that you are dealing with a Robo3 mutation, or if there's any additional scoliosis that is presenting over time. Maybe when you do a whole exome, you can also do a parental segregation at the same time if you're clinically highly suspicious. So I know it's not easy to get blood samples all the time and get it tested with the cost factor that we have to deal with. We just do all both the parents and the affected at one sitting. It will just be very clear to you.
Right.
You have a question? You have a comment? A question? Yeah.
Hi, great cases. So what?
Can you use the mic, please? Mic.
I might have missed it that in case 1, the CNS abnormalities.
We are present in KIF 21.
Yeah. How was it showing up in the child?
There were there was thinning of splenium of the
like
corpus.
in terms of symptoms.
Symptoms, the patient didn't have any other
Fine, he was
symptoms. Yeah,
fine.
he was just slightly low vision and yeah.
Okay. Yeah. And no history of any brain abnormalities
No.
or nothing in the
No.
family. Okay, so maybe it could also be that your genotype is cleaning part of the phenotype and then the rest is sort of. So yeah, I mean again reiterating that maybe going up the generations with Sanger could give you some more information. Thanks.
Thank you very much, Dr. Shweta. Can we have this slide? Yeah. So going on to our next case, we have genetic testing in a case of pediatric cataract, and that will be presented by Dr. Savleen. She's an associate professor at PGI, and she does a lot of pediatric ophthalmology, strabismus surgery, imaging particularly, a lot of genetics. She's published widely, and she's a member of WSPUS, APOS, and of course the other genetic societies. She's won numerous accolades as well. So I'll request Dr. Savleen to start her presentation.
Thank you so much. I'm sure we're going to learn from the audience more than we're going to present. So in a case of a pediatric cataract, its prevalence is equal to that of retinal dystrophies, and we do not talk about pediatric cataract as much we talk about retinal dystrophies. So the causes of pediatric cataract have been largely undermined in our population, I think because of that. The reason largely is because there's a lot of phenotypic heterogeneity that we see. We see different kinds of cataracts, the morphologies are not clear, they're not fitting into one particular category, and that makes it more challenging, the type of test that we have to do for these cases. So I have divided my talk into 3 aspects, what kind of cataract case that you see, and I'll begin with the most, I think which should not miss is that the syndromic one. So a syndromic cataract, a cataract presenting with a syndrome, it's a chance of 15% that you will see a child who is presenting with cataract to have an underlying syndrome. So a case of a 10-year female who presents with a decreased vision in the left eye along with ptosis. She has a normal birth history and she has an asymmetric presentation of cataract. Not only is the cataract asymmetric, the cornea is also small along with the microphthalmos. You see the morphology is typical of a sutural cataract in the left eye. She also has a father who has intellectual disability with both eye low vision, and he had membranous cataract which he had never gotten operated upon. He presented to us with low vision and nystagmus and brought his daughter. The mother was normal. So now we did a pedigree, and you see a lot of males in the family having the disorder, and the child, she was a female, the sibling who was a male was normal, and the mother was normal. So the child's growth, we saw that she had low set ears, she had some intellectual disability but the mother was not sure, she had a short stature, the cardiac hearing assessment, everything came out to be normal. She had a hemivertebra and butterfly shaped vertebra, and the pediatrician thought that she had dental abnormalities, and this is how her teeth looked like. And when we got a dental consult, the central incisors were typical the Hutchinson incisors. If you see them, you remember them. They are screwdriver shaped and they have notches in between. You see a lot of incisors missing, and you see the lower canines are also screwdriver shaped with notches. So the radiographs also suggested taurodontism, that is the root is very small and the teeth is long. And once you combine this together, sutural cataract with dental abnormalities, you have one syndrome, that is Nance-Horan syndrome. So it is typically an X-linked disorder, and it is located, it is because of mutations in the NHS gene, which is located on the X chromosome, and it has sometimes very subtle non-ocular features, so it might go unrecognized. These are the typical features of a Nance-Horan bilateral congenital cataracts, males presenting more severely than females, sutural if you can pick them up at the right time, associated with mental retardation and dental abnormalities. So the males show more severe disease because of a hypothesis, that is the X inactivation. some cells in the blastocyst stage get randomly inactivated X, one of the X gets. So there's a mosaicism. And you see the males have intellectual disability, bilateral cataracts, they present early. And this is how our patient presented. The carrier females have the sutural cataract. They might have subtle non-ocular features. And what was not matching was the vertebral segmentation defects in our case. We were debating as to whether we should just test for the Nance Horan or we should, because some of the symptoms are not matching Nance Horan. So we went ahead and did a clinical exam. We did get a mutation in the NHS, and we were lucky to pick up a large deletion in the chromosome 16, which was explaining the vertebral defects. So we did confirm it in the father, confirmed by a microarray, and then Sanger's in the father. And so it was a classical case where the dental features and cataracts was because of Nance Horan and the segmentation defects because of deletions. So what we learned from this case is that we always examine the child and not just the eye. We are an ophthalmologist, sometimes we miss certain non-ocular features. So for instance, in this case, I always like to say be friends, because what I learned was whenever I have a child with sutural cataract, all I have to ask is to ask them to open their mouth to see, look for this abnormality. The second case is the scenario where I think again ophthalmologists should not miss, because sometimes we are fixating and people say we have to anyways operate, so why go for genetic testing in a case of isolated cataract in the eye. This child who presented a little late had a best corrected visual acuity of 20/200, had some watering, and the cornea wasn't very clear. We tried taking pictures. He seemed to be photophobic. At that point, I thought everything is normal, it's just a cataract. But when I got a PEDS consult, the father came up with a history of seizures, because it's a social stigma in our part of the world. Sometimes parents do not tell that the child was controlled on drugs, and he did have renal tubular acidosis. When the pediatrician told me renal tubular acidosis, I again looked at the cornea. Now I knew what I was looking for, and there was a thickened cornea. It was cataract, cornea, seizures, everything put together. It was a case of hereditary endothelial dystrophy, which I passed as normal myself. We did get an SLCA4 positive mutation, and it was running in the parents as well. The patient was put on sodium bicarb, and we took all precautions and did the cataract surgery anyway. But then deep ocular phenotyping is what I learned. It's not just the cataract, sometimes subtle findings we should be the one who should be picking up CHEDs and not the pediatrician. So I like to be friends with other subspecialties. Dr. Sonam here helped me on this case. The last category is the isolated one, where I think we have again, the question of why do we test a cataract? Again, a 7-year male presenting with decreased vision. A detailed pedigree says nobody in the family has it, but then he says, okay, the mother's sister's daughter has low vision and large family, so we screen them. We screen the mother, and then we screen the sister of the mother. Both have faint lenticular opacities. Again, reiterating that always dilate the parents of a case of an isolated cataract to look for those faint opacities that the parents might have, and both of them carrying the same variant. So we did try to see the genetic variants. It's a poster that we presented this year only in AIOS, if you like to see the results. We try to look at the morphology, try to correlate them with the variants we get. We do have the common proteins which are causing cataracts, and we somehow saw more gap junctions than crystalline mutations, and we're still following them up because we have calcified cataracts presenting to us, which might be because of a delayed presentation in our country, or are they calcified to begin with. Crystallines are by far most common. Same mutations might have the same phenotype. It might not always be the case. And sometimes you pick up unusual morphologies, and we kind of pick up a lot of collagen mutations, because they sometimes have arthropathies, so they just present with cataracts and we diagnose them to have arthropathies. Like Dr. Khan just said, we chase every pathogenic, we like to chase every VUS, because sometimes it's just VUS doesn't mean that it is not significant for us, because you have to answer parents, you have to do prenatal testing, and I think we should chase, especially in a country where we are not genotyping that much. Again, we're lucky we have Dr. Mosaji here, because I really love her article on genetics of congenital cataract. We have a large mutation rate identified in the US, UK data, and we have a lack of genetic studies in cataract particularly. And so there might be underlying mutations that we are missing, which might be life-saving for the kid. The rate of consanguinity is very high. We are a very vulnerable population, and we have to identify and report our variants, because future is the genetics. We can look at the effect of other phenotypes, like other things like myopia and glaucoma, and whether variants have a role to play with. Thank you, Dr. Jasprit, for putting this together for us. He's a mentor for me, and thank you for all the inspiration.
Thank you, Dr. Savleen. Very nicely put across for the isolated cases and where we took, absolutely where the genetic testing would make a difference. So we have the expert. I mean, I've read a lot of articles from her as well. She's done a lot of work on pediatric cataract, and we'd like to have some comments from.
Thank you. I thought that was a really good talk, and you hit the points exactly. So one thing that I've noticed is that sometimes you get referrals and the ophthalmologist who's referring hasn't actually phenotyped properly, and that can just mean an ocular phenotype. You could have an adult with undiagnosed microphthalmia, or it could have subtle anterior segment dysgenesis, and then the whole wealth of the syndromic features. So history is so important. Examining the parents if you get that opportunity. I totally agree with your comment. You should try to get parental samples, and then chasing VUSs and being friends with the family, but also maybe being friends with a lab that can sometimes push it a little bit more, who can do some functional studies for you as well. But I thought all your messages were really good. Thank you.
How do they do it there? I mean, because it's an expensive game here if you do genetic testing for the child and then for the parents as well. So it's not really possible in each and every case. So how's it there? Is it funded by the NHS? Or?
Yeah, so the good thing is, obviously, if you do the main test on the child, then segregation is usually cheaper for you here, I presume. I have to say we're very lucky in the UK. We get to do whole genome sequencing on parent-offspring trios for free on our National Health Service. So I'm totally spoiled.
Yeah, because it's very difficult to convince the child with cataract to have genetic testing and then the parents. So
yeah, basically that's what I mean. If there's a family history and you have the cataract in the family, I mean something which is not, which is like a usual cataract, probably I would not really go in for genetic testing there, but we can have Dr. Arif's comments for this, for such things.
Yeah, that was great. I missed what the last gene was, the last family. You did the screen very, but it's not important. You can tell me later. I just have two quick comments. One is that, more and more with these consanguineous families, I'm seeing multiple diseases. And I think I didn't recognize it before because we didn't have access to this genetic testing. So you always have to be aware of this possibility, as you showed in your first family. Sometimes you're dealing with more than one condition, and that always has to be considered. The other thing I'll just say about the SLC4A4, there's one particular mutation in the gene that causes an ocular-only phenotype without renal tunnel acidosis. And the interesting thing about these patients is they get cataract, they get glaucoma, they also get band keratopathy. But the glaucoma doesn't respond properly to angle surgery. So this is another reason why we have to recognize these cases. If a patient like that starts having angle surgery, it's not an angle problem. The problem is the electrolytes in the aqueous. Yes. And one clue to that is they get this band keratopathy sometimes that is not related to the eye being sick. So it's just another example of why it's so important to have the proper diagnosis. It was really great cases.
Thank you.
Thank you.
Thank you.
Yes, so we are honored and privileged to have our keynote speaker here, Professor Maria Musaji. She's Professor of Molecular Ophthalmology and Consultant Ophthalmologist in Genetic Eye Disease, Head of the Genetic Departments at Moorfield Eye Hospital, London, UK. She's a first-class honors in Biochemistry and Molecular Genetics, Medicine, and Molecular Ophthalmology, all from Imperial College. She has over 39 international and national prizes for her research and 150 peer-reviewed scientific publications. She also is one of the most influential people in ophthalmology in the top 100 list. She's also the president of the UK Eye Genetics Group, and she's an avid clinician, scientist, researcher focused on disease mechanism and new therapies. I'd like to invite Professor Maria for her talk. Thank you.
I'm a bit short here. So good afternoon, everyone. Thank you, Jaspreet, for inviting me to give this lecture, and everyone on the committee. So I'm just going to be giving you a brief overview about genetic eye disease, diagnostics and therapeutics. So the burden of genetic eye disease is vast. It affects 1 in 1,000 people. It accounts for 60% of blindness amongst infants worldwide, and is the leading cause of sight registration amongst children and working age adults in the UK and in the West. Over 500 genes have been identified and are known to affect all parts of the eye. It can be isolated, complex and syndromic, as we've just heard, and these conditions are lifelong and largely incurable, and there are still only a few treatments. So our big challenge in this field is diagnostics and therapeutics. The spectrum of genetic eye disease is vast. I divide it between ocular maldevelopment and then postnatal conditions. So ocular maldevelopment include the structural globe anomalies, microphthalmia, anophthalmia, ocular coloboma, congenital cataracts, primary congenital glaucomas, anterior segment dysgenesis, albinism, etc. And then you've got conditions where the eye is essentially normal, but there are degenerative processes that can occur in childhood or adult onset. And these include the corneal dystrophies, inherited retinal diseases, vitreoretinopathies, and optic neuropathies. And for some of these conditions, up to 90% of patients can exhibit systemic features. So definitely being a friend of the pediatrician is important, especially when you're seeing children with these conditions. So the importance of genetic testing. Patients and families want to know the cause of their condition. We know that it will guide prognosis when you have a family that come in and say, when is my child likely to lose their vision? What's the course of the disease going to be like? The more we do genetic testing, the more we can aggregate our cohorts, and we understand natural history of disease, and we can start to establish genotype-phenotype correlations, which we've already heard about in the first 2 talks. It helps clinicians identify other disease associations. So if a patient presents with bilateral anophthalmia and we find that they have a SOX2 mutation, they may have SOX2 anophthalmia syndrome, where they go on to develop hearing loss, seizures. And so we can assemble the correct multidisciplinary team so we can provide the best care and reduce any comorbidities. We can provide informed genetic counselling to patients. We can tell them how they inherited their condition and their risk of passing it on to future children. And concurrent with that, we can then provide correct family planning advice. So we can offer pre-implantation genetic diagnosis to a number of genetic conditions. This is a form of IVF, where you take the sperm and the eggs, you fertilize it in a dish, and when it's a ball of cells, you take a cell, you check to see if it's carrying the mutation, can only implant healthy embryos back into the womb. And we also have access now to non-invasive prenatal testing, which is where a mother can conceive naturally, and then at around 6 to 8 weeks, you can take a blood sample, isolate the fetal DNA, see if it's carrying the mutation, and then the family can decide whether they want to continue with the pregnancy. Patients who have a genetic diagnosis can access treatments, whether that be gene therapies or drugs, and it ensures that they can access the research that pertains to their particular condition. So there is a multitude of clinical trials out there. They can get involved with research, they can enter into natural history studies, which again helps us. So which genetic eye diseases can we test for? Well, as long as we can rule out an environmental cause, pretty much anything that we suspect is genetic. We used to just go for bilateral conditions, but I would urge you to consider those unilateral conditions. We saw a nice case of upward gaze restriction in the first case, but there are other patients, and in this image here you've got a father that had a unilateral iris coloboma, and he had a son who had severe bilateral iris coloboma and microphthalmia. And so just remember, don't disregard those patients that present with unilateral phenotypes. Patients that have asymmetry and complex phenotypes are another group that we should be investigating. I mentioned if there's no clear environmental and acquired causes, and if the patient has any syndromic features. History is key. The onset of symptoms and signs noted down in chronological order, whether the patient has, for example, night blindness, then field loss, then central vision loss, systemic features including developmental delay, hearing defects, learning difficulties, polydactyly, kidney problems, and make sure you examine those patients. Ask them, were they born with an extra digit that may have been removed at the time of birth in the operating theatre, as you can see with this lady's hand here. Ask about their drug history, because there are certain drugs that can mimic certain inherited retinal diseases. Then go back to the birth history. Ask about whether it was a planned pregnancy, what was happening at the time of conception, knowing that we see the first signs of the developing eye at day 21, a time when parents may not even know that they're pregnant. We need to know what was happening around those events. Whether this was IVF conception, miscarriages, if the mother had any prenatal infections, illnesses, and was taking any medications. And then the family history to ask about consanguinity, any other affected family members, noting down their phenotypes, and to make sure we note down their ethnicity, because we know that certain variants are more prevalent in certain populations, whereas they may be more benign in others. Now, as I mentioned, in the UK, we're very lucky. The gold standard there is whole genome sequencing, so we can sequence all 3 billion nucleotides and over 20,000 genes and their non-coding regions. We can screen known genes, but it allows us to interrogate novel genes in the research environment, and we tend to send parent-offspring trios as the gold standard. And this is increasing our diagnostic rates by 40%. So this is just a case, a 13-year-old Bangladeshi girl who has been wearing glasses for myopia since the age of 7. She developed cataracts at age 11. She has past medical history of learning difficulties, some delayed speech, asthma. Her parents are consanguineous, no other family history. And on examination, she has microcornea and these blue dot cataracts. Vision was 0.7 logMAR with normal pressure. So we applied a cataract panel to this patient, and the results was cerebrotendinous xanthomatosis, and we found homozygous pathogenic mutations in CYP27A1. Now, this condition is characterized by chronic diarrhea, childhood cholestasis, and failure to thrive in infancy. Things that are quite common and could be just go by unidentified. Later on, around the age of 13, she developed the cataracts. And if we hadn't have done genetic testing at this point, we would have missed this diagnosis. She would later go on to develop tendon xanthomas and neurological complications, including neuropsychosis. Now, there is a treatment for this, chenodeoxycholic acid. And if a patient starts this before the age of 25, it can halt symptoms. And if it started as early as her age, it can prevent those. But from our studies, we've shown that over the majority of patients do not get a diagnosis by 25, and therefore you cannot treat or reverse these conditions. So hence, we must do genetic testing when we're presented with children with childhood cataracts, just because we have an 80% chance of getting a diagnosis. So case 2 is actually now a lady, 25-year-old, Caucasian, who had bilateral congenital ptosis. She had a frontalis swing age 2, and she continued her life. She was fine, but she was just about to get married and was concerned whether or not, if she was to start a family, would her child be born with this? So in her past medical history, it's nil. She's got normal menstruation, no consanguinity. She's got bilateral ptosis and epicanthus inversus on examination. Visions are fine. So we applied a structural eye disease panel, and we found that she had a heterozygous variant in FOXL2, which causes blepharophimosis, ptosis, and epicanthus inversus syndrome. This is a dominant condition, so she now has a 50% chance of passing this to her children. It's associated with premature ovarian failure, and this cannot be determined genetically. So in these ladies, we need to provide genetic counseling and careful discussion about family planning. And if we diagnosed her earlier, we would refer the patients to gynecology once they are 16 so that they can have a discussion about ovarian reserve and response assessment for fertility. So the final case is retina. I had an 11-month-old Caucasian mixed Italian-British boy referred to me. His parents noticed that from 4 months of age, he was not looking at their faces, not tracking. There was difficulty with his vision in dim light. He could not discriminate between yellow and blue toys, and he preferred staring at lights. No past medical history, and his vision was 0.9 logmar in both eyes. This was the fundus image that looked normal, but there was a lack of fundus autofluorescence. So with the lack of fundus autofluorescence, the staring at the light, we had a strong suspicion that this could be RPE65. We applied the retinal dystrophy panel, and that confirmed the diagnosis. And so this patient was eligible for voretigene and Apavovec, age 3. And 6 months after receiving the gene therapy, his vision improved from 0.9 to 0.5 logmar. But then after 6 months, his vision dropped to 1 logmar. So just to say that we now have the PERCEIVE study, which is the real-world experience of patients receiving these gene therapies, and it has an update of 103 patients undergoing this, and it showed that there was no significant change in best-corrected visual acuity, but there was an improvement in full stimulus threshold testing. 51% of patients experienced ocular treatment adverse events, and close to 13% of patients develop this chorioretinal atrophy in the area of the bleb. So this is just something that we need to be aware of when we are consenting our patients going forwards for gene therapy. So there are multiple therapeutic approaches out there now. There are those targeted towards the gene or the mutation. Gene therapies that are emerging and maybe close to approvement is RPGR, and we're just starting a dual AAV gene therapy for ABCA4, the commonest macular dystrophy that we see. There are gene therapy trials for CRISPR-Cas9 gene editing targeting CEP290, and RNA therapies using antisense oligonucleotides, again for CEP290, and a trial for USH2A, which causes Usher syndrome and non-syndromic RP with mutations in exon 13. And then there are trials targeted towards common disease pathways, drugs such as N-acetylcysteine, which is a high-dose antioxidant, which is in a phase 3 clinical trial for retinitis pigmentosa. Gene therapies, for example, rod-derived cone viability factor. So the principle of this is that your rods release this factor, and your cones uptake it, and it helps your cones uptake glucose to convert to energy so they can work effectively. And when your rods die off in RP, they don't release this, and so your cones starve to death. So if you re-deliver this back to any residual cones, they can uptake the glucose and maybe last a bit longer. And this is in an early phase 3 trial with a company called Sparing Vision. And then there are trials that are looking at delivering human retinal progenitor cells through subretinal injections to the back of the eye as a form of neuroprotection to support residual photoreceptors as opposed to actually converting into photoreceptors. And a company called J-Site is doing this trial and has completed a phase 2. We're waiting to see if they'll start phase 3 soon. So I'll just leave you with this website, www.gene.vision, which is a resource A to Z on genetic eye diseases. It's written for patients and for professionals, so the pages for patients is all in lay terms, and there is Google Translate attached to this, so you can get it in any language. It's helpful for you if you're sitting in clinic and you see a genetic result with a gene, you can look it up, and it's got the resources on all the trials and the background behind those trials and how to access that. So to conclude, please send your patients for genetic testing. I strongly feel that the inherited retinal disease field has done very well over the years, but some of the non-retinal conditions deserve an equal amount of genetic investigation. Molecular diagnostics can unlock the correct care that we can give for our patients, prognosis, access to research and treatments. There are multiple clinical trials underway, and we have entered the era where genomics and gene therapies will hopefully make a real difference to our patients with inherited eye diseases. So just to say thank you very much.
Thank you, Professor Musaji, for a brilliant presentation and taking out time coming all the way from UK and enlightening us. No doubt, I mean, we've learned a lot, and thank you for everything. And we'd like to have your expert comments. As a keynote address, there are no questions. So we'll move on to our next presentation. So our next presenter is Dr. Diksha Katoch. She's an additional professor at PGI, basically doing a lot of work on ROP, pediatric retina. She's close to 105 index publications and a lot of awards she's won. So a lot of ROP work is being done here. She's doing a lot of surgeries for ROP and of course involved in genetic research as well. So now I'll like to invite Dr. Diksha for a presentation.
Thank you, Jaspreet sir, for the kind introduction, and thank you, Professor Maria, for such a wonderful insight into genetics of eye diseases. My topic is to concentrate on cases with retinal abnormalities, and as far as causes of severe visual impairment and blindness in children in our population specifically are concerned, so the two most common causes that have come up are whole globe abnormalities, followed by diseases of the retina and the vitreous. And as far as the etiology is concerned, hereditary diseases are top the list in terms of etiological classification of the causes of severe visual impairment and blindness from blind school studies from south of India. They have been replicated from Maharashtra, and there's also a study from AIIMS New Delhi. So when we look at hereditary causes of retinal diseases, that is the inherited retinal diseases, it actually encompasses a wide spectrum of disorders which can have systemic associations. So there can be syndromic IRDs or non-syndromic or isolated to the eye. There are different inheritance patterns that could be autosomal recessive, autosomal dominant, or X-linked. These diseases are also characterized by sometimes incomplete penetrance and variable expression, and these could be progressive or stationary. They could be generalized or predominantly macular or involving the optic nerve. They could, as far as the photoreceptors are concerned, they could be predominantly rod cone, cone predominant, or cone rod dystrophies. There could also be vitreoretinopathies. So as ma'am has also said, that this is a genetically heterogeneous group of disorders with a wide variability and a lot of phenotypic overlap. So the disease that is retinitis pigmentosa, which we commonly diagnose as of today, has more than 100 gene associations. So really, if in today's era, if we want to make a diagnosis of retinitis pigmentosa, we need to do a genetic testing so that we can do a genotype-phenotype correlation for these diseases. Of all the diseases, of all the genes that have been mapped to retinal, inherited retinal disorders, at least 328 have been identified as of March 2025. And you can see that the slope that this is expanding. So this area is growing. So I'll just show, one, and if time permits, another case where the use of genetic testing helped me in identifying or making a definitive diagnosis for a case. So this case I just saw a few months back. This was a 10-year-old male child who presented with complaints of predominantly floaters and decrease in vision in the left eye of 1 week duration. There was no other significant history. The past history was important, that he had been diagnosed as an exudative retinal detachment at 1 year of age, and And since then, he had had poor vision in the right eye. So this was the right eye, no light perception, cornea showing a band-shaped keratopathy, and you can see that yellow glow because of total exudative retinal detachment with massive subretinal exudation. The slides are moving on their own. Is there a timer setting to it? So the left eye, the visual acuity was 6/12. Anterior segment was unremarkable. The posterior segment, we see this wide field fundus photograph, which is showing predominantly a vitreous hemorrhage. And temporally, we can see that there are occluded vessels. So what was this case that we were dealing with? There was no exudation. So we did a fluorescein angiogram. The fluorescein angiogram is showing blocked fluorescence because of the hemorrhage. We can see areas of capillary dropout. So that's about it. And we can see areas of new vascular leakage. So we made a clinical differential of 1 FEVR, coats, but bilateral, yes, rare, but can present. Was it an acquired condition? Was it a vasculitis? Was it IRWAN? For vasculitis and IRWAN, the only odd point was the other eye, which had an exudative detachment at birth. So FEVR and coats was top on the list. Still, we were keeping a possibility of FEVR, but the parent screening was negative. So how do we go about from this case? We also noticed that there was an abnormal lock of gray hair on this 10-year-old child. Was this important? So routine investigations revealed that the platelets were low. Hemoglobin was also low, normal. TLC was also normal, but on the lower side. There was deranged LFTs, and a workup for vasculitis was negative. We did a laser indirect ophthalmoscopy as guided by the fluorescein angiogram. So what should have been done? Can we stop here? No, we cannot stop here because we haven't yet arrived to the definitive diagnosis. So a genetic testing was ordered, and we found these compound heterozygous mutations in the one in the exon and one in the intronic segment of STN1 gene, which was consistent with an autosomal recessive inherited cerebroretinal microangiopathy with calcification and cysts, and this was also confirmed on parental segregation in both the parents. So we tried to fit into the phenotype. So yes, because there was no other family history, it was autosomal recessive. There was sign of that gray hair which fit into premature aging. There were some signs of a low count, pancytopenia. There were some liver abnormalities and vascular and retinal telangiectasias, though the telangiectasias was not prominent, but on the nasal we looked back, and on the nasal aspect of the fluorescein there were very isolated few telangiectatic conditions. To fit into the picture, we ordered an NCC head, and it did show the calcifications, multiple of them in the subcortical white matter, right frontal, parietal and left occipital region, and a bone marrow was also advised after consulting a pediatric hematologist, and it confirmed the presence of a markedly hypocellular bone marrow with a cellularity of 5 to 10% and reduction of the normal hemopoietic elements. So the diagnosis of a Coates plus syndrome, which is actually a telomeropathy, the gene complex is part of a 3-gene complex, that is the CST complex, that is responsible for shortening of the telomere lengths. Until date, only about 4 patients have been reported. The problem is that there is a high risk of mortality because these children have risks of GI bleeds, and that can result in mortality. So how did this genetic testing? It helped us in a lot of ways. It helped us in establishing a definitive diagnosis. It allowed targeted investigations. It helped in guiding for appropriate follow-ups with the appropriate multidisciplinary team. At the back of the mind, we have a prognosis for this child, and can we help at this time? It helped in parental counseling. We have counseled this child to the parents to undergo and consider a bone marrow transplant. The child is under follow-up in hematology unit for any signs of worsening counts and drop in hemoglobin and the LFTs. So case 2, this was a young adult but with history of low vision and difficulty since childhood, who was referred as a case of choroiditis to the uveitis clinic. His examination was 618, 636, and he was myopic. And why it was labeled as choroiditis? Because of these pigmented scars that were seen in both eyes in the superotemporal quadrant. So, and an OCT showing the presence of cystoid macular edema or foveoschisis. The autofluorescence also showed hypoautofluorescence in the areas of the pigmentation, but what was notable was this ring of hyperautofluorescence that you usually don't see in a uveitis case. This is more consistent with the presence of a retinal dystrophy. And the fluorescein angiogram also did show some leakage, and possibly that can lead on to confusion. But if you look carefully at the angiogram, we see that the leak is not really from the vessels, it is at a deeper level. So we did a full field ERG, and this is what the full field ERG, the left panel shows what we expect to be normal. So there was markedly diminished dim flash ERG, also the dark adapted, and we saw there was reduced flicker responses. It was consistent with an electronegative ERG. A genetic testing revealed NR2E3 homozygous mutations, and which was segregated in parents as well. And this was a variant which was consistent with the enhanced S-cone syndrome. So again, how did genetic testing help? It again helped in establishing a diagnosis. It avoided unnecessary treatments and investigations and helped in guiding follow-ups. So why genetic testing is important in retinal diseases? I think it has been very nicely highlighted by Professor Maria as well. Whenever we have a strong suspicion of an inherited retinal disease, and for that we need to do a complete ophthalmic examination, including history, ancillary testing. It helps us to classify and establish a diagnosis. It helps in prognosticating. It helps in generating awareness, because in our population, mostly the parents or the family members don't even know that possibly they may be dealing with a patient of a genetic disorder. And definitely it helps in genetic counseling and educating the family members for subsequent pregnancies, and even for finding candidates for suitable gene therapy, as ma'am has also shown the results of Luxturna. The RP65 mutations, we have more than 20 mutations that are linked to LCA. And our population may not be having those kind of mutations. So we need to look at our own population cohort. So to conclude, gene-based diagnosis of IRDs is rapidly expanding. It is providing new insights in the diagnosis, and gene therapy, as has been shown, appears to be promising in some cases. Thank you.
Thank you, Dr. Diksha, for those interesting cases. Any questions or comments? Yes. Dr. Arif? Dr. Arif, after that, you can ask.
Once again, great cases. This is really a great session. That first case, you know, that gene, I've never seen that before. That's really interesting. So that's it. But I just want to make a quick comment. You know, I'm a big advocate for genetic testing, obviously. But that second case that you showed, that ERG was pathognomonic for enhanced S-cone syndrome. So if the genetic testing came back without an NR2E3 or NRL mutation, I would tell them go do it again because you didn't find it. So sometimes we have phenotypes that we know it has to be this. And if the lab doesn't give us the answer that we're expecting, then we tell they're wrong. Yes. So this is why it's so important to be clinically, you know, accurate and aware of these things.
Excellent cases, Dr. Katoch. Just one question, 2 of your cases had VUSs. They segregated, but is that enough to establish and say confirmatively that this is the diagnosis and counsel the patient?
Yeah, because if when we looked at the literature, all the other cases had also a STN1 mutation. So possibly the intronic variation that was there, that was a novel one for us. And you saw that there are only 4 reported cases till date. Right. So possibly that VUS is possibly a novel mutation. So that's what we are writing up this case as well. So just not all VUS, possibly VUS, we really need to go deep down into our population cohort, because we may be dealing with a lot of novel genes and mutations that are linked to IRD phenotypes in our population.
Yes, but then even if it's a VUS, like you go ahead with the counseling as if it is
definitely, because other investigations are all fitting into the diagnosis, so that is why.
Thank you.
Thank you. We can move on to the. You have a comment? Yeah, we can take one comment.
Sorry, just on the VUS, so because she did the MRI and it showed the calcification, then you can upgrade it based on the phenotype. If you're just not sure, you still have to tell them, we cannot 100% confirm this, but we think this is the cause, because the labs will only issue a report if they're 100% certain.
So moving on to something in the retina and beyond. Can you have this? Yeah. So it's good to have a genetic team from doing ophthalmic genetics in PGI. So very fortunate and lucky that we are all of us are together here. doing a lot of pediatric ophthalmology. So I would be presenting two cases rather, in what we do in neuro-ophthalmology. Yeah. I mean, yeah, the phenotype is pretty clear here. It's just the genetic testing for why we get it done. So the finding of optic atrophy in a child is always a cause of concern, because so many causes. I mean, it could be anterior visual pathway or the posterior visual pathway. So we do have improvement in diagnostic abilities related to neuroimaging and molecular testing. It's not always possible to get accurate results with electrophysiological testing in children. Obviously, they're so uncooperative. And confirmation with molecular diagnosis and correlating to the phenotype narrows down the differential diagnosis. So we have a 5-year-old child who complains of some diminution of vision, both eyes blurring, the way children would tell. Since 3 months, there's no pain or redness associated with it, no pain on ocular movements. No complaints in the past, uneventful birth history, just this child is affected, nothing else. And then when we do the ocular examination, we find that the visual acuity is dramatically down. It's about 2/60 in both the eyes. The child is unable to read the demo plate even when we do the color vision testing. So basically, these are some of the clues where we find that there's some kind of an optic neuropathy which is going to be there. And so when you examine the posterior segment, what we see is a white disc. So the margins are relatively clear here. There is abnormal branching which is there from the disc. So it looks like a primary optic atrophy, although there is the pallor is developing in the other eye as well. So the number of causes which can happen to cause optic dyspallor in a young child, because we've seen this even with the children with the raised ICT, post-raised ICT, I mean having dyspallors, not just disc edemas. So when we do the OPD testing, because obviously we have to put this all together and try to fit in what we are dealing with. The OCT macula is all fine. The visual field, whatever the child is cooperative, you see the fixation losses are pretty high, because obviously the child is with low vision. What can you expect? But yes, we do get a fair idea that something involving the center is there. It's like a central scotoma which is coming up in both the eyes. The visual field testing, if you see the nerve fiber layer, it's decreased just 52 and 58 here, and so is the ganglion cell layer. It's quite less. So basically something has been there for quite some time. So now we start to take a retrospective history, because a lot of neurological issues also which we were suspecting. So there's no such problem. There's no weakness of the limbs or paresthesia, no headache, vomiting, seizures, which could be the cause. So the impression is obviously a bilateral possibility, a primary optic atrophy. And what can cause this? Well, optic neuritis is again one of the causes, although there is disc edema, but the picture is not always clear. Then you have mitochondrial optic neuropathies like LHON, or you could have a nutritional cause. It's a bilateral optic atrophy, or it could be a toxic optic neuropathy. So basically all these things come into your mind. So had we sent this child basically to neurology or maybe to a pediatrician, probably a lot of things would have happened. So if we just see the differential diagnosis, basically we try to just narrow it down what is really happening, but in a child we can't really tell that if it's just one eye followed by the other. The child just has optic dyspallor and something which is a diminution of vision in both the eyes. So really can't tell what is going on. So we get a whole bunch of investigations to rule out whatever the simpler ones before going into more detailed investigations. And then we do ask the pediatrician to look up. The systemic evaluation is normal. They consider it as an optic neuritis and start treating with IV methylprednisolone. But there's no improvement, and then the patient comes back to us, and then what we order is what we call genetic testing. When we do the genetic testing, obviously we have to, the genetic testing is an older one, because obviously we could get it done at a much lower rate. So the child is positive for 11778A mutation, which is seen in LHON. Now LHON also has 3 types of mutations. So this one has a grave prognosis, so that's not really good. So we start the child on coenzyme Q basically after taking the pediatric consultation, but the visual acuity really doesn't improve here. So what we can do here with genetic testing is just basically prognosticate it, what is happening, and maybe had just been one eye being involved, probably this treatment would have helped us in salvaging the other eye visual acuity. But here, just prognosticating, that's what really helped us, and not going into any systemic problem that the child sometimes can have with these LHON, like a neuropathy or a myopathy. So the second case is a 10-year male with bilateral progressive decrease in vision since 3 years. Everything else is unremarkable. The visual acuity is 636 and 660. Pupils are fairly good reacting, normal size. Anterior segment is fine. And the posterior segment, again, we see what the disc, it is a disc pallor. And here what we have is a temporal disc pallor. So it's a temporal disc which is affected more as compared to the nasal part. And so when we do this electrophysiological testing here, there is a prolonged latency of the P wave. Again, with the low visual acuity, sometimes really difficult. Again, in a child, it's difficult to pick up a visual field, but yes, there is some signs or clues which are coming up to that the child does have a central scotoma. So these are some of the clues what we get. Again, the optic neuritis is really something which is always the first on our list, basically. So it's a 10-year-old. So we get all these NMO mogs done. It's negative. OCT macula is fine. MRI does not show up anything. Then the next step is obviously genetic testing. And when we do the genetic testing here, what we find is a likely pathogenic variant in OPA1. So that's something here. Now we are having an autosomal dominant optic atrophy in this patient. The other patient we had LH1 was just a 5-year-old. Basically, LH1 would present later as compared to OPA1. So something when it's not really fitting in, probably I think to know the diagnosis and to further narrow down your basically your differentials, a molecular diagnosis should be there. So basically 2 cases which highlight what the patient could have. And OPA1 usually has a better prognosis, whereas an LH1 with the 11778 mutation has I mean, you can just guide them what they can do, because the prognosis is not really good in those cases. There are certain other mutations in LH1 which probably have a better prognosis. There is also probably they do get back their vision in some of these cases. Thank you. So we are happy to have any comments or questions, anything, or we move on. What start on? Idibinon, yeah. So one thing is that the child already has very low vision with an optic disc pallor. The other thing is in India, Idibinon is 45 milligram, which is available. You have to give almost 900 milligrams. And so Idibinon has been shown to have a good effect where the other eye is not yet affected. So salvaging the visual acuity. The other condition where it has been effective is the 11448 mutations, which has a good prognosis. In these conditions, it has not been shown to have really an effective outcome, especially if in this case where you have you can have pallor in both the eyes with such a low visual acuity. So we'll move on to our next presentation. We have. Can we have the slide, please? Yeah. So we have Dr. Sonam. She is associate professor at PGI again, who specializes in cornea, cataract, and refractive surgery. Does a lot of work in pediatric cornea. She has a keen interest in ocular imaging and pediatric cornea. Published a lot of articles, and she's also the editor of the Chandigarh Ophthalmologic Society, and also has a keen interest in various you can say imaging and newer techniques which come up, and tries to present it at places where probably and trying to win whatever she can. So that's the passion should be. I mean, very passionate clinician, no doubt. Dr. Sonam, your presentation.
Thank you, sir, for the kind introduction, and I'm really grateful to you for giving me this opportunity. And I'm happy to see Professor Ken here in the audience and other audience as well, because again, as Dr. Sabreen mentioned, we are going to learn a lot from the audience. And as Dr. Maria pointed out, that compared to every other specialty, cornea is less explored when it comes to genetic and phenotyping. So I have few cases to discuss. So coming to the first case, here is this 1-year-old girl who presented with bilateral corneal opacity present since birth, and she had global developmental delay along with a short stature. Here we can see the photo of her face. There's this telecantthus is there, there's bilateral ptosis, broad nasal bridge, and philtrum is absent, and there's abnormal facies. Along with that, she had this epiphyseal, premature epiphyseal short, fusion, and ocular examination shows a low IOP and thick corneas, and axillary length for change was fine in this case. On doing an AIOS and UBM, here we can see that there's presence of this slightly thickened cornea, but there is iridocorneal lenticular adhesions in both eyes with the typical notch in the left eye we can see at the endothelial stromal side. And again, once we look at the phenotype of the ocular phenotype, then along with the systemic features, we thought of the Peters plus like everything, and referred her to the genetics department for further evaluation, where they did find some skeletal abnormalities in this patient. Along with that, there was this COL2A1 gene mutation. Again, it was variant of unknown significance, which is many of the majority of the case are like VUS actually. But in our case, again, the ocular phenotype was suggestive of type 2 Peters anomaly, while the systemic or the genetics evaluation showed something else. And moving on, because I'm going to compile the 3 cases together. Another child who again had systemic and abnormal facies with secondary history of secondary consanguinity, hypotelorism. We can see the epicanthal folds very prominent, long philtrum, depressed nasal bridge, brachydactyly. You can see the short stubby fingers, edema all over the limbs, and large genitalia, cafe ulae spots all over the back. And coming to the ocular examination, we can see that there is this peripheral corneal opacification, and central also is more, central is less involved compared to the periphery, and we cannot differentiate where the limbus is, more of a peripheral sclerocornea one can say, with very, very small hypotenuse eyes. Again here, when we look at the UBM, we can see that there is presence of this lens which is stuck on the endothelium along with the iris, and the moment we see this, we think that, okay, could it be type 2 Peters anomaly or Peters plus, because the child is having systemic syndrome as well. Then again, this child became a candidate for further evaluation. So on getting a genetics test, we found these 2 genes. One is the CREP gene, which was more of a missense mutation, and Menke-Hennekam syndrome, which has facial dysmorphism, feeding difficulties, microphthalmos, deafness, which our child also subsequently had, and all these features that our child had fit perfectly into this syndrome. While you must differentiate this from Robinson-Tivy syndrome, which is on the same gene, mutation on the same gene, almost on the same axon or at times, but there is loss of function mutation compared to a missense mutation. We did advise a parental Sanger sequencing. Along with that, it is mentioned that this syndrome you must do genetic counseling, very good genetic counseling, because some of these children can have failure to thrive because of the feeding difficulties. Some may need gastrostomy as well. So you must do a good genetic counseling. Like in our case we did, but the parents were quite skeptical about getting it further. That is one of the obstacles which we all face. Another child, again, having the central corneal opacity bilateral with iridocorneal adhesions with excavation of the stroma, who ultimately had this GDF3 and oval 2 mutation, again, not commonly seen with Peters anomaly again. This child otherwise did well by bilateral SEPA with optoclaridectomy. So we advise further Sanger sequencing of the parents, which showed a GDF3 mutation in the mother, and that leaves us with the oval 2 mutation, again not associated with Peters anomaly, which is more commonly seen with endothelial dystrophies like PPMD3 or maybe CHED. So again, these were the 3 cases where phenotypically they were more like pointing towards Peters plus, but genotypically they are showing some other mutations. Maybe Professor Ken can help me out in the end. So this is another child who presented to us after open globe injury repair, because he was he had a trivial trauma while he was writing with and the eraser hit his eye, and he had OGI. After OGI repair, he was referred to us for aphakia management. Here we can see that there is presence of bilateral bluish sclera, and ocular, like the cornea appears relatively clear. And on doing a Schemfleck imaging, you can see there is very thin corneas, that's like diffusely thin corneas in both his eyes. And the primary surgeon did not realize while doing a suturing, she did not mention any difficulty in suturing. While looking at this, this child definitely had this thinning. And we, ultimately we did do a proper workup of this child. But I want to show that 6 months later, this child had opposite eye injury. You can see that there's iridocorneal adhesions are here with the perforation, and we did a patch graft, and luckily we got a small tissue which we could send for histopathological examination, where we can see the lamellae are very loosely arranged in the eye with various stains, and his genetics, which was done earlier 6 months prior, was positive for a ZNF469 mutation,
which is positive for brittle cornea syndrome, type 1, while the type 2 shows this PRDM5 mutation, both of which are part of this Ehlers-Danlos syndrome spectrum. So we did a screening, family screening, where they said that the elder brother has been on treatment for primary congenital glaucoma for the past, from the time of his birth, because the moment he was taken for examination, parents felt that his eyes looked quite prominent, so he was examined at when he was an infant, and he was diagnosed to have primary congenital glaucoma. And his old records showed that in all the readings and the EUS that he underwent elsewhere, his pressures were like 8 or 6, not more than that. And they had also mentioned that his optic disc is fine, but he was still kept on a thing, and he was diagnosed to be having keratoglobus. So when we knew that he also has the same disease, because he has bilateral bluish sclera and a very steep cornea. Here on the AIOS2025, you can see that the cornea is very steep and the deep anterior chamber depth. And then both the siblings did not have posterior steepening like you see in keratoconus, even though keratoconus can also be associated with brittle cornea. So we did a Sanger sequencing, which had the same mutation as ZNF469, like his younger brother. And another feature that we found here is, which the pediatrician also pointed out, that the father as well as the siblings, they had dolichocephaly, which was another feature, but it's a very uncommon feature. So, okay, there is still some time. I just want to show that when you see a child of corneal opacity, always do a thorough phenotyping and a deep phenotyping of the child, and do not miss the posterior segment, because this child presented with this thick corneas and bilateral opacities, but then also had some ultrasound features, and then the child was finally diagnosed to have FEVR or LRP5 mutation positivity, which has this exudative RD component. So just the spectrum of cases I wanted to discuss, and I'm happy to take comments and Professor Ken's comments as well. Thank you.
Yeah, why not?
I'd like to acknowledge my
those are very
pediatric center, APC
very
team.
interesting cases, and we'd like to have expert comments from Dr. Ken Nischal.
They are wonderful cases, actually. I think you demonstrate very nicely that we really shouldn't be. Oh, look at that big head there. Let me stand out the way. We really shouldn't be using the term Peters anomaly, because you're trying to find a genetic cause for a sign. It's like saying you're trying to find a genetic cause for a cough. So I think your deep phenotyping was very, very helpful. In my experience, Peters plus children always, the true Peters plus syndrome, due to a mutation in beta 3GLTL, they always have a cleft palate. I've never seen one without a cleft palate. I don't know if anybody else has. They always have a cleft palate. So I wouldn't call it Peters plus until you see the cleft palate, the short arms, and they have this sort of rather very big forehead. Now there was a case that you showed where you had a change in a gene that gives you Fanconi anemia.
Yes.
I can tell you categorically that that was the cause. And you need to go back and you need that child looked at with a pediatrician, because they get malignancies.
Yes.
And we published a paper on Fanconi anemia, and what your clinical phenotype was identical to the paper that we published.
Okay.
You thought it was another syndrome, but that was Fanconi anemia.
All right.
So you have to go back and get that child urgently looked at by a pediatrician.
Yeah, he is at a follow-up.
Yeah,
Yes.
but yeah, great cases. And I think that what you demonstrated is that without imaging, you really don't know what you're looking at.
Yes.
And I think the other thing is, there was a case that you showed, the LRP5 case, the last one. So we published with, oh my God, Shulja Tibrewal. We put Peters anomaly masquerade. And we've both had two cases where it looked like Peters anomaly, but the lens was pushed forward either because of an exudative detachment or familial exudative retinopathy. So what you're showing again is that the opacity in the cornea is only a sign.
Yep.
And it could be caused by different things.
Yes.
And that case shows very nicely that it could be the retina.
Yeah.
Well
Thank
done.
you. Thank you, Dr. Ken.
Thank you for those insights. And that's how molecular diagnosis is helping us. It's just not what we are just seeing. obviously identifying the cause as well, what's important. So, do you want to have any comments? Yeah, please. Yeah, yeah.
I think in optic atrophy, the most important thing is once you make the molecular diagnosis, it helps you modify behavior. I mean, it's really important for idibanone or coenzyme Q, but you now have to say to them, stay away from secondary smoking, don't drink alcohol, because we don't know what the trigger can be, you know, and if you put oxidative stress, you know, don't do recreational drugs, because they could lose their vision completely. So I think that's, for me, that's the most important thing, because the parents have something to hold on to, and so does the child, though it's very difficult, you know, teenagers and all the peer pressure they have.
That's very important. I mean, because psychologically they would be quite upset as they grow, the children, and can get into any of these smoking or alcohol, and they have to be told that yes, it's going to be worse if you get into these. So that's an important point. Thank you.
So is it you advocate whole exome, or it's a targeted exome sequencing? What is the take-home thing which you would like to tell us as clinicians?
So part of it is down to your clinical suspicion. So you don't have to test for all genes necessarily if you really think that it's a particular one. Say if it's aniridia, you're not going to do whole genome. You're going to go straight for, well, if it's a child, you're going to do an array to look for WT1 PAC6. But if not, you're going to just look at PAC6, and you've got 98% chance. But, you know, just be aware that there are overlapping phenotypes, pseudophenotypes. So, you know, spot diagnosis, you can't always do that. So you just have to be careful. But I totally agree with Ken's point. So we should slightly start moving away from retinitis pigmentosa, Peters anomaly, you know, because those are kind of general descriptive terms. We should kind of start moving towards a gene-based classification for these conditions, because then we can absolutely then give proper guidance. May not have a treatment, but we can absolutely guide lifestyle changes, dietary requirements, etc., based on the gene, rather than a kind of a blanket, oh, you mustn't do this or you should do this. So down to it, you would apply a targeted panel if you're not sure. If you know the gene, you can go for that. Again, it's about cost and what you can do and what you can't do. But even when we do whole genome, we don't just do a whole genome. We would do a whole genome and then only apply a targeted panel depending on what we're looking for. Sometimes it's also beneficial to apply 2 panels. So if a child has a learning difficulty and, for example, cataract, you could do 2 just to check. And then remember as well, if you have children with developmental delay and learning difficulties, you may want to start with an array first, because that's cheaper and quicker before going into exome as well. So.
Can we have this slide? Yeah. So, yeah, we have a last speaker, probably maybe the best. So, Dr. Sushmita Kaushik, who's a professor at Advanced Eye Center. And of course, these are just a few of her achievements. Probably there are a lot of pages, so probably I can't be reading each and every achievement. No doubt she's done a lot of work in pediatric glaucoma, and probably it doesn't need that much of an introduction. I'll request her to please start off with the presentation.
Thank you, Jaspreet. It's always nice to have close friends on the panel because they're very kind to you. Thank you for having me on your course. He told me to present, can the slides move, please? Yeah. So he told me to talk about the one case, but I'm going to talk about the one case which taught me so much and made me eat a lot of humble pie. So this is story 1. You think you're a hotshot pediatric glaucoma person when people refer to you from far and wide. So this is like unilateral PCG. Something is in your head that why are these unilateral, but we've seen them, so acha they are. Literature says 25% of ophthalmos are unilateral. We do a combined trab with trab, and he does fine. The cornea clears, the pressures are fine, so far so good. 1 year later, the pressures start rising. We do an additional goniotomy, And something tells you something is amiss because there's some sort of ptosis, but then you've learned that ophthalmos and large eyes can also have a pseudotosis possibly, and you're wondering, okay, maybe that's the reason. And then 3 years later, again, the pressures are rising, and this time he's required a tube. So we go in, we put in the tube, the cornea clears again. Now the ptosis is a little marked. And at 7 years, he's controlled on 3 meds, but now I'm not bothered about the glaucoma as much as the ptosis. So why intractable glaucoma and why the ptosis? And by then we have the whole exome, which is affordable. And we screen and we do a targeted, which they call a clinical exome sequence, which is 6,500 genes which are analyzed for all the exomes that have been implicated in disease. There's no pathogenic variant, but I get an email. So this is the report that I get. There's no pathogenic variant because the phenotype that I put in is intractable glaucoma, congenital, and ptosis. So I get this email saying, we haven't found your phenotype, but what we found is a splice problem in the intron of NF1. And then I tell my residents to call him back, lift up his shirt, and there are the cafe au lait. And then you really, really eat humble pie that for 7 years you actually hadn't examined the child completely, but the parents swear that these are recent onset over the last 2-3 years, and they really weren't there when he was born. So you sort of think that possibly you're okay, then that you didn't really miss it, they actually weren't there. And then you ask the lab, and this is the conversation you have to have, you ask the lab to include NF1 into the report, and this is the final report that we get, it's likely pathogenic. So this was an oversight because we then screened for optic nerve glioma, we screened for the sphenoid, we screened for the cranium, and he did have a posterior optic nerve glioma, which the neurosurgeons are saying hold on to because it's not progressive as yet. Let's see how it works. So then once we had this insight, this oversight, the universe sends this 3-month-old baby with unilateral glaucoma, and this time we are sure and we say, okay, let's see, look for the cafe au lait, and there we are. And yes, so now we know how to diagnose neurofibromatosis in a case of unilateral newborn glaucoma. The ptosis was marked even after surgery, but we looked at the mother because she would never come in, and he would come in with the dad. And in the kind of crowds that we have, we are so thankful that the child is brought in, we don't really ask. So at this time we asked the father, is the mother in? Where is she? Because he looked completely fine, and there you are. She has leash nodules, she has plexiform neurofibromatosis, and she would always sit with the ghungat or the sari right down to here, because not so much modesty as much as she didn't want people to see her face. So of course there was NF1 again, and we didn't have to wait for genetics to get the whole gamut of a pediatric and neurosurgery referral, and both of us are following up this patient as well. So then we have a 3-month-old baby where the mother complains of drooping of the right eye, and it was enlarged, and we immediately looked for cafe au lait again, and they were glaring because this time they were on the cheek and they were scattered on the trunk. So we clinically diagnosed again, NF1, sent to PED, sent the sample, and of course it came back with an autosomal dominant NF1 as well. So the older stories came back to haunt us, because whenever I don't understand anything, I put them all into a folder saying weird iris, weird cornea, weird this, weird that. And I came up with one which said unexplained unilateral glaucoma, and there you are. Today, I would have diagnosed this baby as NF1 possibly, just looking at that S-shaped lid. But at that time, I had honestly no idea. The cornea clears, the pressure lowers for some time, and as the child grows, the S-shaped lid comes up. We lost this child, and they came back to the ER with panophthalmitis, which had to be removed because the parents just disappeared over the next 2 or 3 years. And now, of course, he's grown up. He's a 6-year-old naughty boy, but he has a prosthesis. And we hope we've given him some life despite losing that eye. So the key takeaways is always be suspicious about unilateral newborn glaucoma. You never know. And unless you've ruled out everything possible, don't just think it's de novo. Look out for abnormally shaped lids. That's what we now know. Look out for cafe au lait spots. They might not be so obvious when they're very young, but keep following them up. make sure to get a systemic evaluation, especially for a CNS involvement, and take the help of genetics whenever in doubt. I acknowledge the series of senior residents who work hard to make me the little that I possibly am, and I invite you all to the Indian Pediatric Glaucoma Society meeting in Madurai in December this year. Thank you very much.
Thank you, Dr. Sushmita, for highlighting the real value of genetic testing, what we need, how it can help us. And before we close, any comments, any questions? I think that was quite clear. And everybody learned what to do in neonatal glaucoma now. So thank you, everyone. So once again, I thank my panelist speakers and the audience for sitting and listening, and thank you everyone for a patient hearing. I'll just request the speakers for a photograph here.